Yes, hi. Good afternoon, everybody. Welcome to the COVID-19 webinar by Tryon Medical Partners. This is the March 24th session, which will be recorded and posted to the Tryon Direct website. I am Patrick Brady, as Gaston said, Senior Vice President at Tryon Direct, and I'm responsible for business outreach. Today, we have participants from both Charlotte and Raleigh. Those that have been with us in some of the past events from Charlotte, we welcome you back. As you know, this is an ongoing, up-to-date, real-time conversation that we are looking to have with business leaders like yourself. And for those in Raleigh, thank you for joining us today. You know, we are a medical practice on the front line, and you should know what we know. These sessions were started for you so that we can share what we're seeing and hearing and hopefully help you cut through some of the overwhelming amount of information that is out there. So you will hear perspective today from a medical practice. And for those in Raleigh, we are Tryon Medical Partners, the largest independent practice in Charlotte. Nearly 100 doctors, primarily internal medicine, but we are a multi-specialty practice. If you have the webinar up on your screen, we have the agenda for today. So we'll share with you the latest updates. Secondly, it's time to put panic aside, doing the right thing for social good and for the good of your business, which is what you're here and interested in hearing about. Exponential increase in cases, what it means and how to flatten the curve. And then the Charlotte and Raleigh perspective. Business continuity, practical insight from the medical community, dealing with legal implications. And just so you know, the Tryon Direct COVID-19 Task Force is meant for real-time responses. The intake is through the TryonDirect.com website for any questions that you might have. We have expertise across several different people, including clinical, including legal, including business, and just know that we are there to help for that resource as well. And then Q&A. The way we'll do this is we'll have 30 minutes of information we'll share. We will set aside 30 minutes for questions. And please feel free to join in on the chat or *6 to unmute your phone. And just so you know, the speakers for today, from this end, Dr. Dale Owen, CEO of Tryon Medical Partners and practicing cardiologist. Stephen Gage, PhD, organizational psychologist with Gage Benefit Advisors. Granger Pierce, labor attorney with Van Oy, Reutlinger, Adams, and Pierce. Gaston Gage, Chief Strategy Officer of Tryon Medical Partners. Thole Gill, Chief Financial Officer, Tryon Medical Partners. And you're going to see some visuals on the screen. Those are really meant just to keep us grounded as we go through the information. Most of the conversation will take place hopefully in a good back and forth exchange. And as I said, we'll take questions online or by phone. And with that, I will turn it over to Dr. Dale Owen.
Hello, my name is Dale Owen. I'm the CEO for Tryon Medical Partners. Previous internal medicine doctor, now non-invasive cardiologist and leader of this group. Most of you know that we left Atrium Hospital with 88 doctors, now close to 95 physicians, but that's really not important here, but just to tell you who we are here in Mecklenburg County. So in regards to a recap, there's been several of these webinars, and I think that it's important that everybody kind of catch up and have heard the same thing at the very beginning. So I'll do a very quick recap, and we can certainly go over any of it again if you'd like. First of all, the COVID-19 virus, now known also as coronavirus and SARS-2 virus and so forth, is a new virus from animals now to humans for the first time. And so we don't have much information on it. We don't know if the temperature change is going to affect it. We don't know if it conveys immunity. And what does that mean? Whether or not if you get it once that you can't get it again, and if so, how long is that immunity conveyed? Is it a month, 6 months, 10 years, or what? We don't know if it's going to mutate and have other strains like influenza does, which is why we have to put multiple strains of influenza in vaccines. We know that on average, we believe that it conveys contagion or is likely to spread to 3 people per individual that has it. That's higher than influenza, which is about 1.5 to 2. The incubation period done by Johns Hopkins University on 181 patients that were in Wuhan. And by the way, there's no other data yet on incubation period, but it was 5.1 days on average, but it ranged between 2 and 16 days from the time of exposure to the time of first symptoms. So you can see that that's a real issue. We do believe now that there are people before they start having symptoms that they are already spreading the virus. That makes it even more difficult to monitor. Symptoms generally are, the big ones you hear about are cough and fever. There's a lot of people who are now talking about taste sensation being altered. It's a little bit different than the flu influenza virus, which tends to also have the same cough and fever, but is usually associated with a headache. And what's unusual, I wouldn't say unusual, but we should know something about this virus in that 80% of the cases are mild, 20% of them are severe, and a quarter of those 20%, or a total of 5%, are considered critical. The death rate around the whole world has been 4%, but in the US, it's only 1% right now. And why is that? Well, we believe that it's because we're testing a lot of patients in the mild phase now when we have more tests available, when previously we were only testing patients in the severe phase. And so obviously those people are more likely to have severe illness and die. And now we're getting a better understanding of what the true incidence of death is. Now, South Korea did a same example of this, and they tested a lot more patients as well, and they found 0.6% death rate. It's a little higher than influenza, but not by much, but significantly less than what we saw as death rate around the world as this thing first came about and hit the United States. So current testing, let's be honest about this. We don't have enough testing equipment. We never will have enough testing equipment. We're not going to be able to test everybody for this. And since it's already all over the United States, how many patients we have doesn't necessarily mean that much anymore. We need to find the people who are the most seriously ill. And so now testing recommendations have changed. It's not people with mild symptoms who have very low grade temperature and a mild cough. It's everybody above that. Quarantine is still the same. If once you are tested, that you're quarantined for the time period it takes to get the test back. All right, so that's quite variable as well, in that LabCorp and the initial testing was done about 3 days. Now they're getting overwhelmed and having to set up 3 more testing sites around the nation. And we've seen it take as long as 6 to 7 days to come back. Well, with an incubation period of 5 days and another 3 to 6 or 7 days, you might be looking at something that happened 11 days ago. And so we're really behind the 8 ball from that standpoint. We do not test anyone, no one at all, no matter what their exposure was or where they've been or anything, if they have no symptoms. And specifically, now where you've been or coming from makes no difference. And it really shouldn't have, because it was all over the world. We just weren't really willing to admit it yet. So exposure, if you're exposed to somebody and who has it, and you're one of the primary people that's around them, a spouse, a child, a coworker that was within 6 feet, those people are supposed to go on quarantine as well until either they have symptoms and are tested, or up to 14 days. if you're a secondary exposure risk, more than 6 feet away from people and so forth, it's okay for you to wear a mask and stay at work. There are some new guidelines now about if you test positive that you should stay home for 7 days after a positive test and at least 3 days after you have stopped having fever. So if you come back 7 days, but you still have temperature, that doesn't make any sense. You have to be at least 3 days without fever and at least 7 days at home. All right, so let's talk a little bit about this incidence and why it's really such an issue in the United States. Well, understand that China, South Korea, and well, those two primarily, they quarantined their populations immediately at very low rates, and they kept their total incidence down significantly. But that's not what's happened here. That's not what happened in Europe. Europe's gotten blasted with this. Italy finally made the decision to close its borders and everything else, and everybody stay at home in a national quarantine. Spain has done it. France has essentially done it. The United Kingdom is finally getting that message as well, and other places throughout Europe. But the cat's out of the bag. Same thing here in the United States. Last Tuesday, we had reported 4,661 cases. Thursday, 9,415. Saturday, 19,000 cases, which, as you can see, is more than a doubling. And that had been going on for the previous 10 days. And so let's say, just take last Saturday, 9 days ago, was when that really represented that 19,000. Because that was 5 days of incubation plus 4 more days of waiting on the test to come back, and now it's even longer. So that 19,000 last Saturday was reflective of the count that was likely positive 9 to 11 days before that. And then 7 days ago from last Saturday, it would have been 38,000. 5 days ago from last Saturday, 76,000. 3 days ago, 152,000. 1 day prior to last Saturday, which was last Friday, 304,000. 1 day after Saturday, which is now Sunday, which was 2 days ago, 608,000. Today, 1.216 million people are estimated to potentially already have this virus. So, you know, this is going to be pretty hard to stuff the genie back into the bottle. New York has just been decimated with this. And the other problem is that there's just not enough testing to go around to see exactly how many. So this is really an underestimate of the true amount of exposure we really have. So here we think we might have 1.216 million. It's an underestimation. Now you're to the point where you had two options. You could do a national quarantine and stop this thing by starving the virus, by preventing it from having more hosts like humans to infect, or you could just allow it to do what it's going to do. And we've gone further and further down the route of being half pregnant and not really doing anything definitively. We needed to have quarantined about a month ago to be able to really blunt this curve or flatten the curve, as you hear Fauci and others talk on the news from the NIH. And so we have prioritized our economy over doing what was right from the standpoint of a contagion issue across the United States, and we've done neither one very well. And so we're suffering on both sides of this. And everybody's confused, what are we really going to do? You know, some states are quarantining completely. Other states are kind of putting their big toe in. We had heard the governor of North Carolina was going to issue a quarantine stay at home and then didn't do it. And so now Mecklenburg County finally has come out and said this is a stay at home policy now for everyone. And that's now a significant issue. We're still waiting on seeing what Capitol Hill is going to do. Hopefully something later today will come out. The governor did not act fully here. You to do a national quarantine, well, basically now that the thing's really out of the bag, genie out of the bottle, it's going to take a major incentive package by the federal government, and I think they're looking at somewhere between $2 and $2.5 trillion, and hopefully that'll be enough. We'll see, but that's where we are right now. With the way we test and the delay in the testing, what I call it is fighting a war that's already happened. It's hard to go to the battlefield and do anything about something where the war happened, 9 days previously. So we're really chasing our tail on this one, and we're so close to whether or not we just need to take our lumps and open up the economy, which you probably heard Trump talk about yesterday, versus a true national quarantine. And if we did that, the areas of the country that would probably benefit the most from it would actually be North Carolina, the Southeast, and the upper Midwest, because so many other places across the country are already hammered with this, that it wouldn't make as much difference there. But it could significantly make a difference here in this area of the country. However, if we're the only ones to do it, and our state does it and surrounding states don't, it's not going to make much of a difference, because we have the 10th largest airport, and all of this going on. There's a lot of travel would be reinstated. So I'll leave it at that, and we can go from there.
All right, a few practical questions, and we can certainly take questions in the chat as well. Dale, the advice of virtual visits, for example, what is the importance of those?
I think that virtual visits are a real key to this whole process, both from the medical side and the patient side as well. The virtual visit is designed to keep the patient at home so they don't come into a site and infect everyone around them. And that makes perfect sense. But the issue around virtual visits is that not very many physician groups were fully adept at doing it and ready with their platform and so forth. I instructed our group over 3 weeks ago to have 100% virtual visit capability within 2 weeks. We have it, we're doing it. But the problem is a lot of these virtual visit platforms were not robust enough to handle the volume of visits that were going to come. Some of them blow up, and we still look for really good, stable platforms. Some are significantly better than others, but it clearly is a way for the patients to stay at home when they feel poorly, not infect others. And then the challenge is for physicians to have a robust enough platform, and also the remuneration for virtual visits. Physicians, when so many visits are leaving the office, it's really important that the non-hospital physicians, independent doctors, remain completely able to maintain seeing their patient volumes, because they're now on the front lines of this. They have to see their chronic illness people, and their subcritical illness people, and keep them well so that they don't wind up entering the hospital, because these hospitals are going to get slammed with this problem going on. Hospitals here in Mecklenburg County are securing beds from wherever they can get them. And, we've already even volunteered our ambulatory surgery center and 4 GI suites and prep areas and so forth to the hospitals and so forth, and they're going to use them. There's not going to be enough beds to handle this. It might be the first time we see rationing of care, but as a result, though, it's really critical that the physicians on the outpatient side be able to see all these patients that they see routinely with chronic illnesses, so that they don't wind up getting poor care and wind up getting into trouble and have to go in the hospital into a system that's already been completely overrun by this COVID virus. You know, they're just going to have a hard enough time even seeing heart attacks and strokes and appendicitis, much less the other chronically ill people. We've got to keep those folks out of the hospital.
Let me shift gears now to a business question. Gaston, I think this is best for you. What can employers expect to see in claims volume, acuity levels? How does that look over the next weeks and months?
Yeah, great question. So I would say this for the folks on the call who are in self-funded plans that run a self-funded plan, the elective procedures in this country have basically shut down completely. Dale can speak to that in a second. But what does that mean? That means that non-urgent care, hips, knees, dermatology, routine GI like colonoscopies, that kind of thing. Those things have stopped almost completely. And so for your medical plan, as sort of dire as a lot of the information is that you're hearing, one of the things that you will be experiencing in the next some months is you will not be getting claims in your medical plan for any of those kind of procedures. It's just going to be the urgents. It's going to be the heart catheterizations, the brain aneurysms, the appendectomies, the urgent things, but it's not going to be the back surgeries, the knee replacements, the hip replacements, those kind of things. And so you're going to see a significant drop in claims from the elective procedures that you were seeing in prior years. Now, what you will start seeing, depending on if your population starts experiencing the COVID-19, is, for those that Dale mentioned that are in the mild to moderate range. So basically that, 80 to 90% of claims, or maybe even 95% of claims, you shouldn't have a significant expense for those people, medical expense. I get that they're going to be out of work and those kind of things, which is very significant, but there will not be a significant medical claim there. There frankly aren't any prescriptions to give them, those kind of things. But for the people that go in the hospital, and this is definitely going to be a fluid number, the insurance company actuaries are starting to talk about $70,000 per person that becomes inpatient. Obviously, that's going to depend on how long they're in the hospital. Do they go to ICU? Do they go on a ventilator? How long are they on a ventilator? If they survive or not, that kind of thing. But so you're going to see a significant drop in your elective procedure cost. You're going to see an increase, obviously, in something that you haven't experienced before, which is the people that go inpatient on the COVID-19 infection.
Let's take a minute from that. And Granger is on the line with us. Granger, so much happening even today. What do you think is most pressing that this group should hear about?
Thanks, Patrick. I think the most pressing thing is what we've just gotten in the last hour from Mecklenburg County, and with apologies to all of our new friends in Raleigh who have joined on, and Wake County who joined on. This is really it's extremely pressing for folks in Mecklenburg County, because it's going to kick in effective Thursday morning at 8 a.m. And we'll put a copy of this up for folks to get. Originally, when it was published, there may be some confusion. We retrieved a copy when Mecklenburg County put it out right off the bat. For those of you all who have looked at a copy that have a PDF with 8 pages, just be aware that you've got half of it. Apparently, it's someone at Mecklenburg County who scanned in half of a double-sided document, so it's not complete. We've gotten the complete copy of the document, but just so everybody knows, it's basically what amounts to a stay-at-home shelter-in-place order from Mecklenburg County that closes what a few things they say. Number one, they're going to close non-essential businesses and operations you can go through the actual order and see what's in there. But the order says right off the bat, you can only leave the home for what they say are essential activities. And there's a list in there of what is essential activities: health and safety, to go out and buy groceries, necessary supplies and services, engage in outdoor activities. It's like, for example, going out to go running or to ride your bike. And two, this is a big one, to take care of other folks or to perform certain types of work. And it's important to go through and look and see in there if you are currently, if you own a business, run a business, want to see if you're affected or not. There's a list starting on page 8 of that order that defines or delineates, itemizes what would be considered to be essential businesses and operations, such as the first one on there: stores that sell groceries and medicine, food, beverage, and agriculture, the media, organizations that provide charitable and social services, gas stations, businesses needed for transportation, like auto repair shops, hardware stores, certain critical trades, like HVAC, painters, exterminators, cleaning services, laundry services, restaurants that are still running off-premises consumption. So basically restaurants that are doing takeout. I'm going to skip down to the end: professional services, so real estate, legal, accounting, that kind of stuff, and hotels, motels, childcare centers, manufacturers, supply chain. So it's a long list of stuff. I'd encourage you to look at the actual actual order to see what's on there. But that's critical for folks in Mecklenburg County because it's going to materially impact what you're dealing with. I also just want to mention very briefly, we talked about it last time, but just so everybody's aware of the new changes to unemployment that were in Executive Order 118 from the end of last week. We touched on those briefly, but just so everybody knows, with where we are on those changes, because I've been getting a lot of questions about them. Essentially the two most important parts of that are, for our purposes, the 1 week waiting period for unemployment's gone, and if somebody loses their job because of the coronavirus, that's not going to affect the employer's experience rating. I've gotten some questions about a reduction in hours and is that going to entitle somebody to unemployment or not? And right now, the short answer to that is we don't know. It's touched on the Division of Employment Security's website, and the governor mentions it in the executive order that a reduction in hours itself may entitle you to receive unemployment benefits. Unfortunately, we don't have any additional information on that right now. One last thing I want to touch on very quickly, because I have gotten a lot of questions about this. The new Families First Coronavirus Response Act that takes effect on April the 2nd. Right now, it applies to employers of 500 or fewer employees. I have gotten a lot of questions about the reference in the law that says that the Department of Labor can designate or can decide that employers of under 50, so 49 or fewer employees, are exempted from those requirements. And I've gotten a lot of questions saying, well, okay, we're below 50 employees. Does that mean we're exempt, or we've heard that we're exempt? Unfortunately, the bottom line on that is the Department of Labor has the ability to designate those businesses as exempt. But right now, what the U.S. Department of Labor is saying is they don't expect to have any regulations out on that until April. If that changes, I'll let you know. But as of right now, as long as you're 500 or below, the law applies to you. There is currently no carve out for 49 or less employees. Patrick, that's all I've got right now. Happy to answer any questions anybody might have, but I'll wrap that up for mine.
Granger, one last thought, if you would. The Paid Sick Leave Act is.
Yes.
Can you briefly mention how that ties in?
Okay. Yeah. Thanks. So very quickly, the paid sick leave The paid sick leave component, it's one part of a two-part, two parts of the Families First Coronavirus Response Act that's been passed. The paid sick leave component essentially says if you're out for one of six different reasons, that are in the first three are essentially you're out because of a quarantine order. And actually, let me stop. I talked about that on the last call, and I don't want to rehash too much other than to say if you're out for one of six reasons, you're potentially eligible to receive up to 80 hours of paid sick leave. The big one I think that's going to apply here for employers in Mecklenburg County, to tie this into what we're dealing with right now. Right now, since we've got this new order from Mecklenburg County that says what amounts to a shelter in place effective 8 a.m. on Thursday, that's right there. Item number one on the Emergency Paid Sick Leave Act is if the employee is unable to work because of a federal, state, or local quarantine or isolation order. If the employee can't work or telework, if they're in a situation where they have to be able to actually physically come to work, if it's a service occupation where they can't work from home, starting on April the 2nd, those employees are going to be eligible. That's going to be one of the reasons that the employee is eligible to receive paid sick leave. So they're going to be entitled to get up to $511 a day. That's the cap for up to 80 hours.
Okay. All right, Granger, thank you for that.
Sure thing, Patrick.
Let me pause here for just a minute. I don't see any questions in the chat, but anybody on the phone want to *6 and jump in with questions for any of us? Okay.
Hey, Granger, this is Dale. Did you mention anything about in Mecklenburg County declaration today that physicians, medical offices are still to stay open, and those are one of the primary groups that people should still come to for essential services.
Absolutely. Yeah, thanks, Dale. That's a good point. On the 6th page of the order, there's a specific reference to, that says that folks can leave their residence to either go to work for or obtain services from any healthcare or public health operations. That's hospitals, clinics, pharmacies, any of those healthcare related things. So great point, Dale.
I want to go back to, was there a question?
I'll add something, Patrick, if I could. You know, today, some of you guys may have seen this. Mike Krzyzewski came out with a video basically thanking the physicians, nurses, staff for being on the front line and really taking the bullets on this thing. They're literally putting their lives at risk. We know at Tryon that we will have people that will become infected and may have poor outcomes. And I'm a UNC guy, so it's hard for me to say something good about Mike Krzyzewski, but I will say that his video today, he was basically saying, as a community, what can we do? And I'll tell you something, that there is and Dale mentioned this earlier in his introduction, that there is a real need for what the medical community refers to as PPE, personal protective equipment, gowns, gloves, masks, face visors. And we have 75 or 80 employers on the call today, and you guys have relationships, you have capabilities yourself, and if you know of people that can help produce some of this equipment. When I asked Atrium and Novant in Charlotte today, I said, we're getting ready to go on a WebEx with a large number of Charlotte and Raleigh employers. Do you want me to ask them something? They said, please get us equipment. Please get us equipment. I mean, we are, and Dale mentioned this, I'm not sure he gave the number, but I believe, Dale, that just Novant is adding, hundreds of ICU beds to take care of the intensive care, the critically ill patients. And those frontline people need this equipment. So if you guys have manufacturing companies that can manufacture this kind of equipment, if you need for us, Dale and our team, to give you some more specifics about what that is, I mean, there's a massive need for that kind of equipment in the medical community. So Dale, I don't know if you want to speak to that at all.
Yeah, Gaston. I don't have the exact probably don't have the exact number from Atrium, but I know that Novant has the ability to mobilize as many as 487 beds from a standpoint of ICU care if it were necessary. We offered ours as well from our ASC. We can add to that. Doesn't matter who we really give it to. But that may be an issue. The PPE is described that, for those of you who don't know, I'm sure some of you are medical people and do know, it's the face shield or goggles, mask, gloves, and a gown. One day we'll have limitations in a gown. Another day will be the mask. Right now it's N95 masks or surgical masks. So that's an issue. We've asked the dental community around Mecklenburg County to contribute as well. We have retired dentists bringing in what they had left in their offices, and we're now actually able to use expired N95 masks. It's not the mask that's the problem, it's the rubber things that go around the ear that might deteriorate, but the mask itself is still very functional. We're now going to start, you're going to see us all over. People are going to be washing and sterilizing their equipment. We know that in full sunlight and the proper bagging and so forth, that should actually, with appropriate UV light, be able to sterilize that type of equipment. So hopefully we'll get smarter about the use of it and not just throw it away with one use. The hospitals tend to do that more than anybody because they come in and out of rooms so many times. And we're already limiting the visitation so that others won't have to use that PPE as well. But we're actually going to start up a second clinic for testing off-site as what we call satellite clinic. I think it's really, really critical that the independent physicians jump in here really hard and try and help out what's going to be just an overwhelming hit to these hospitals. So yeah, I don't know the exact capability of Atrium.
Question, can you use homemade masks made using, this is HVAC, filters and cloth, or really anything to manufacture a mask that's effective?
Any kind of mask will have, some barrier, but it's not as good as an N95 mask, but it is certainly better than nothing. So the answer is yes, you can. But it's not as good, but it's certainly better than nothing. And don't be surprised if we're not seeing that type of thing used in the next month or so. We will run out of PPE within about the next month.
Okay, second part to the question, Granger, this might be for you. Has Mecklenburg County established a procedure for requesting a designation that a business provides essential services?
In terms of what's in the order, Patrick, no, there's no procedure in place. They don't, and I think the reason why is they've defined essential businesses and operation to be number one, healthcare and public health operations, number two, human services, number three, essential governmental functions, and number four, essential infrastructure. And then there's an itemized list of essential infrastructure. So there's really no provision in place, because if it's not listed, I think the answer to that's going to be it's not going to be considered an essential business or operation.
Okay. All right, thank you. So clarification, Dale, on the mask. Is there would there be a time when medical professionals would use something other than N95?
Absolutely, it's coming. I mean, we're definitely going to be forced to. It's not being manufactured fast enough. And unless other businesses jump into it, like the way businesses did in World War II to, create tanks and bullets and guns and uniforms and helmets and all those types of things, and they restructured their businesses, then we are going to run out of protective equipment. It's just a matter of when, not if.
Follow-up question, Dale, is something you said earlier. The tests today, the initial tests that came out, you said are running 6 to 7 days turnaround because of the volume. There are other tests coming out. I wonder if you could say to folks what those are, comment on the cost if you know it, availability.
The first tests were sent into the health departments and so forth, and then the United States government had to go ahead and unleash or prevent, get rid of this law that didn't allow others to create these tests. Once they did that, then LabCorp and other Quest and others came out with their various lab tests and capabilities. Now they're overwhelmed. There are other groups, Athrix and so forth, that have these one-day turnaround tests. They're more expensive though, but they're also testing for more things. They can test for flu, other viruses, other potential bacterial antigens, and also the COVID at the same time. And so it's a better test, and it comes back earlier. It's about $150, but the patient doesn't have to pay it. But it is billed by the lab company to whoever the insurer is, and they get paid for it. But the patients themselves don't have to pay for it. But the other tests from LabCorp, hopefully we'll see that come down in a number of days as they open up more sites for running these studies.
All right, thank you for that. Questions on the chat or on the phone?
I would say, Patrick, one thing that you had on your slide that's important, and we've been talking about this for decades, trying to encourage people to get primary care physicians. Those of you on the phone, I would encourage your employees and their dependents to sign on with a primary care physician, because if they get ill, there's not going to be enough bandwidth of primary care physicians to take care of all the ill, and they just won't have anybody to go to. And now with all the subspecialists that are basically standing down right now because their services are basically dictated by the government, not needed to, in part to, some of the PPE. They just won't be, they would have a choice but to go into the hospital, which is already going to be inundated. So I would say, for the first time in my 37 years in this business, I'd say that it's imperative for everyone to have a primary care physician. They can sign on virtually. We have Ray Coppage on this call, who represents a large independent practices, several of them in Raleigh, of course, Tryon and other practices in Charlotte. But everybody needs to have a primary care physician, needs to be in the electronic medical record of that physician. So if they get sick, they can be cared for rather than going into the hospital system, which is going to look like, Dale mentioned World War II. It's going to look like World War II type of stuff at some point, because they're just not going to be able to handle the volume of patients.
Gaston, a follow-up question to you and Dale. Would we, the medical community, consider using specialists to triage and treat? So if specialists are doing less right now and the medical system gets overwhelmed on the front line with primary, would we consider using specialties?
would we consider using specialists to do primary care work?
Yes.
Sure. I think that first of all, to understand how these specialists work, when you do residency in internal medicine, you do 3 years of adult medicine only, no pediatrics. You do a lot of ICU medicine, some ER, things of that nature. Internal medicine is somewhat uniquely qualified for the chronically ill adult patients. Now, within internal medicine, there are a lot of subspecialties, including gastroenterology, cardiology, and so forth. And all of them had to train 3 years in internal medicine, just like the ones who stopped at 3 years and now are called internal medicine primary care specialists. These other subspecialists now are certainly capable of coming back and doing primary care. There's no question. Now, they're not used to it, but it wouldn't take long for all of those memories to come right back. And we're very likely to need them and be happy to pull them in. Now, primary care also includes a significant group of physicians, which are the family practitioners or family practice doctors. They don't have a lot of subspecialties within their specialty itself, but they are just as adept at handling the primary care needs. I'm really interested in seeing what's going to happen when we get the first major barrage of COVID patients that hit the hospitals and in the ICUs, and then they send them out because they're not quite as critical anymore, and they're going to be sent home, or they're going to be sent to their primary care physician. I'll tell you what, the primary care doctors are going to get a rude awakening of the level of care that I think they're going to wind up providing when this thing really gets very acute. Because the hospitals are going to need to get them out of the hospital quickly. It's almost going to be like being in the step-down units, coming out of ICUs into step-down units and then to the regular medical floor where the primary care doctors would tend to see them. I think the primary care doctors are going to essentially wind up being that step-down unit right out of the ICUs in the future, in the very near future, probably within a month.
Dale, we
Yes.
have a question about a lot of information in the public about only the people that are over 60 being really in jeopardy, and the people under 60 or under 50 may get sick, but there not as much jeopardy as the older people. Would you speak to that?
Yeah, there are a couple patients right now on vents in their 20s and 30s right now, ventilators right now here in Charlotte who have COVID-19. So yeah, that was the first data that came out that was the sickest of the sick. But remember, whenever you're doing a sampling of only a certain portion of a disease process, then you're always going to have sampling errors. And from a statistical analysis, that just made absolutely no sense. Now, sure, the sickest people are more likely to get hit with respiratory things and have more problems. So there is definitely that. However, well over half the people contracting this and getting very ill are the people under age 52. Lots in their 20s and 30s and so forth. Infants are getting hit. The young children and the early teens, not so much from severe illnesses, but this myth of it being only 65 and above is truly a myth. There's clearly, any bell-shaped curve. Yes, the peak of that bell-shaped curve is at around 65 and so forth, but there's a lot of it to the left of that bell-shaped curve into the much younger ages. So, I think all the people who went to the beach over spring break, watch out, that's going to be the next group because, they've got about 5 days under their belt. They're just about ready to have their first groups of symptoms.
Okay, we have a few minutes left. If anybody wants to jump in with a question, *6 on the phone or type it in the chat. If not, I want to take Dale back to something he said earlier. And we often get this question. It's part of the reason we're doing this. Dale, you talked about we may be up to, what, 1 million cases at this point. If you just start to double the number of cases, but what does it look like in your opinion 30 days from now, 60 days from now?
Well, I don't want to be really flippant about it, but if I was just going to guess, and if we haven't been testing sufficiently enough, and if we have the sampling error where we're testing mostly the sick of the sick, and now if we're going to say we're not going to test the minor illness people, and now we're forcing it to be the sampling error, and we already see that there may be 1.2 million already in the United States, 30 days from now, try those doubling rates. Okay, 1.2 goes 2.4, becomes 4.8 in 4 days. Do I think there could be 10 million people, 20 million, 50 million people? I think if you just look at just the doubling rates and just the fact of the exponential curve, and you assumed all of that continued, I mean, you're really talking 50 million people. There are a lot of epidemiologists and so forth that think that anywhere between 30 and 50, as much as 60% of this country is going to be infected with this virus.
Okay.
The biggest issue is going to be what? Does it convey immunity?
Dale,
We don't know.
we have a question online encouraging, and we may all need to jump in on this one. Subject of encouraging employees to establish a primary care physician. Will PCPs require a new patient to schedule an appointment, such as a physical, to establish themselves as a new patient?
I'll answer it this way emphatically: hell no. These are times that none of us on this webinar, nor our parents likely, nor our parents ever saw anything like this. In World War II, it wasn't really on our grounds except for Hawaii and a little bit on the West Coast. But the last time something this significant hit our shores was 1918. And there were all kinds of problems with that, but I think that the issue is going to be that it's not business as usual. It doesn't, rules don't apply in a pandemic, and we have to do what's necessary for people, not what, the insurance company protocol is, okay? So if a patient needs to see me, and they don't have a primary care provider, I may act as their primary care provider for several days or months or whatever. So will anyone else. And even when we see people come for the first time at our drive-through clinics, we may set them up with a primary care provider, but nobody's going to do a full physical exam on those folks and so forth. We need to take care of them and get them out of the office and so forth, and get them back home. Protocols don't exist in situations like this.
And I would say this. I would say this. We have a Try and Direct website. We have a task force, and I'm sure Patrick will get that in a minute. But anybody needs a primary care provider in Charlotte or Raleigh, let us know, and we'll get one to you very, very quickly. Just go to the tryondirect.com. It'll be spelled out how you ask questions and that kind of thing. We'll take care of that for you.
We got time for one last question, and Granger, if you need to say this is a follow-up, that's certainly fine, but guidelines on what type of paperwork necessary for the sick leave or paid FMLA?
Great question, Patrick, great question. And right now, the short answer is we don't have any. The Department of Labor has said they're coming out with a poster. It may have come out today. I have not looked yet. It's supposed to be out by tomorrow. A poster to meet the posting requirements for employers for the sick leave and emergency FMLA. In terms of paperwork, I would expect that the DOL at some point will come out with some paperwork, hopefully in the next month, to help employers document this. But in the short term, starting on April the 2nd, and I would go ahead and start looking at this, putting this together now. I think that in the short term, ideally what you want to be able to do, and this is really going to come into play on the back end when employers are trying to get the payroll tax credits for any money that's paid out under this. Ideally what you want to do is obtain written documentation similar to what you might get for FMLA leave. If it's a doctor's note, if it's a statement from the employee, if it's for a non-health related reason, get something in writing from the employee, and if the employee's out, from the employee's healthcare provider, that you could put in your file to establish the employee was out for one of these qualifying reasons.
Okay. All right. Thank you for that. And we're right at 5:30. I'll wrap us up here with a couple of thoughts. And Gaston just mentioned the Try and Direct website, and there's no shortage of sites where you can go to get COVID-19 information, and they're all great. And even on our site, we refer to the WHO and all of the medical community that's putting out guidance. But that is only a portion of why we created this task force. It is more so to interact and to give back to the business leaders yourselves information that you find helpful. So please take a look at it. These webinars, after we do them, they are posted out there. We have other information that we are making available. We have this type of Q&A that goes out there as well. And then most of all, know that any of us that are part of the medical community are willing to jump in and help you with anything that you're confused or concerned or don't understand or you've just learned about. So please do take advantage of that. And I'm going to let Dale close this up here.
So to everybody, I think right now there's a lot of confusion. You know, when you look at all the media aspects of things, you see the president saying one thing, you see Fauci saying something else on a different network, and so forth. And there's just not a unified policy of how we're handling this. I think that is conveyed very easily, or I should say poorly, across the whole country. We're seeing that, and each of the governors doesn't know exactly what to do. And quite frankly, then it gets down to the individual and the employers, and nobody knows exactly how they're going to handle this. And we sympathize and empathize with you. Everyone's afraid of, massive financial impact and bankruptcies and effects on their workforce and how they want to help their workforce and so forth, and their hands are tied and such. So this is always coming down to the fact that the federal government, we're lacking clarity as to what they want to do. Hopefully they'll come through today and be able to tell everybody how they're going to handle this from a financial standpoint, so that all the employers across the nation can do the right thing. Otherwise, it's going to, as you can tell, it would wind up being mayhem, where employers are forced to do things that they really don't want to do, and then lots and lots of millions of people get injured in the process. So clarity is the key. Everybody's looking for it. We basically are at a crossroad where we're going to have to decide either a national quarantine that may help some people, or sit back and take our lumps and do what we can to help the healthcare system not get overrun. That's sort of where we are. But I just want to say I appreciate everybody listening. Love to have comments, questions, and so forth, even afterwards. And best of luck to everyone going through this.
Okay, with that, thank you all very much. We appreciate your time. Have a good rest of your day.